Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's journal summaries, which this week were brought to you by our authors Millie Cassé, Kimiko Dunbar, Joshua Belfer, Shannon Marcus, Dendrick Cooper, and Clay Smith. Okay, let's get straight into the first article, which was titled Prophylactic Antibiotics in Gunshot Fractures, with concomitant bowel injury to prevent fracture-related infections and other infectious complications, out of the journal Injury. So we know already that if you've been shot, a single dose of broad-spectrum antibiotics is good. It's good prophylaxis. And then if you have a hollow viscous injury, then continuing that up to 24 hours, that's also good. However, there's other situations in which you would really suspect that the person might get an infection, and would consider prophylaxis perhaps for longer durations because you think they'd be higher risk. These authors wanted to look at patients who have a bowel injury from a gunshot wound, and that same bullet continued and caused a fracture. The East guidelines classify these injuries as Gastillo type 3 injuries and that you should treat accordingly. But not everyone agrees that that's really an open fracture, nor are there always large tissue defects associated with it, as you might expect from a Gastillo 3. With large caliber rifles, then you get a lot of devascularization, but that's not always the case with every gunshot wound. So these authors wanted to do a retrospective study, and they identified 140 patients across 6 years who had gunshot wounds, bowel injuries, and a fracture. They found 140 of them, which is pretty impressive, I'd say, because that sounds like a very specific population. But I guess if you're finding this many of them, then it's a question that we kind of need answered. 74% of these patients had pelvic fractures, 34% had vertebral fractures, and 9% had proximal femur fractures, which leads us to believe that people had multiple fractures because that adds up to more than 100%. What they found was that the duration of prophylactic antibiotic therapy had no association with the development of infection. However, there were only 2 patients in this cohort who actually were diagnosed with the fracture-associated infection. So it's really hard to draw conclusions when you have so few of the actual target outcome happening. Of course, to put that on top of that, this is retrospective data, and these patients were identified using ICD-9 and ICD-10 codes, and it's hard to say what to really do with this. I'd say that some kind of prophylactic antibiotics are definitely going to be necessary. I think treating this as a Gastillo type 3 injury is very reasonable. However, it's not obviously beneficial to give longer doses of prophylaxis. In a spoonful, perhaps long durations of prophylactic antibiotics are not helpful when you have a bowel-to-bone fracture from a gunshot wound. But they also didn't seem to be harmful, so do what you think is right. And then let's move straight into the third article, titled How Many Minutes Matter? The Association Between Time Saved with Air Medical Transport and Survival in Trauma Patients, out of the Journal of Trauma and Acute Care Surgery. While everyone agrees that air transport of trauma patients can save lives, speed of delivery is only one of the ways that it does that. So how much time actually needs to be saved compared to ground transport for it to be worth it for you to hop into a helicopter? Of course, logically, you seem like you'd want to save as much time as possible, but how much is really worth it to save? So far, the guidelines on this are not really very clear. What's the number to shoot for? What's worth it? And this leaves crews to make a lot of judgment calls. Ideally, we'd have more data on what would be a reasonable amount of time to save, that you should take that extra step. And these authors thought that they could find a time cutoff that would be beneficial. To do this, they did a retrospective cohort study of 280,000 trauma patients over 16 years old from a Pennsylvania database. They were able to see the actual transport times, and they were able to calculate the counterfactual transport times. That is the transport times of the method of transport that wasn't taken, in order to compare the amount of time saved. For patients meeting the physiologic or anatomic national field triage guidelines criteria, there was indeed a survival advantage if you were saving at least 13 minutes. And if you were saving 17 minutes, there was even more benefit. For patients meeting AIR Medical pre-hospital triage score criteria, the benefit threshold was at 23 minutes or more, with even greater survival impact at an odds ratio of 1.22. So you could really be saving quite a few lives if you're saving time. Interestingly, they found that really the amount of time that you need to save is kind of 30 minutes, because if you saved even more time, presumably because these are long transport times in general, no matter which way you're transporting them, then you lost any of your benefit really. The graph seems to plateau after 30 minutes. So it's really just in the shorter transport times where you're saving not as much time, but that time is going to be extra critical, where this is really important to shave off a few minutes. That is survivorship bias at play, since they excluded patients who are dead on arrival. Now, this paper really relies on sort of back calculating what the transport time would have been. A much better estimation would probably be an estimate which is made at the time of transport, because if this data, as it was taken from anywhere from 2000 to 2017, a lot of roads and changes get put into place then. And so if you're just Google Mapsing something modernly, that transport time might not actually reflect what it was 20 years ago. And so it can be hard to actually make those estimates. This applies really mostly just to ground travel. While I'm sure helicopters are in some ways a little bit faster now, overall, you're still going to take a pretty straight route between destinations. Now, there are many, many, many moving parts when you're talking about air ambulances, and so this is just one more number for them to keep in mind. But it's a good start, and it definitely helps inform us about how much time is worth saving. 13 minutes doesn't sound like a lot of time to save to get a whole helicopter up in the air to go get that patient, but this could be saving lives. In a spoonful, transport times matter. If you can save 13 to 17 minutes, depending on the triage guidelines that you're looking at and this patient qualifies for, then you could be doing really good by your patient, a mortality benefit. Okay, that's all the articles we're going to cover from this week. Let's do a quick wrap up of everything we talked about. From the first article, at some point, you just have to kind of give up on prophylaxis. See if they have the problem and then treat it if they do. For patients with bowel injuries from a gunshot wound, which also causes a fracture, perhaps 3 days of prophylaxis is really all we need. From the third article, in sick trauma patients, if you can save as little as 13 minutes in select patients with air ambulance transport, then you might be saving lives. Now, if you are hearing this right now, then you are not a part of the members feed. You heard 2 articles. You could have heard 5 articles. What were the articles that you missed? Well, one was a review and guidelines on complicated UTIs in children. Another was a meta-analysis on fluid resuscitation in patients at risk of fluid overload. And then, what should you do about BP management when it comes to cerebral edema post-stroke? Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.